the basic answer paper they have to write, at the end of it, their hands are already paining. So, writing such long answers would have definitely been a task. So, today we are joined by our expert faculty that we have here today to share their experience, to share their understanding on this topic. We have Dr. Khyati Mehtalia, who is the owner of Sakhi Women's Mental Health and Child Guidance Clinic at Ahmedabad. Madam has held several positions. The list was very long, so I have cut it very short and put it together that she has held several positions in various committees of IPS, West Zone, as well as Gujarat State Branch, and actively very involved in community work as well. In addition to all this, having a balanced life, she is also an Upantya Visharad in the Hindustani classical music. So, welcome, Khyati ma'am.
Thank
And
you.
our Thank you, ma'am. And like Sir said, you accepted on a single phone call. So, thank you for being here with us. And the other faculty that we have today with us is Dr. Amit Kulkarni, who, as a person of very few words, just sent in 2 lines and asked him, Sir, please send me something so that I can introduce you during the program. He said, I'm a practicing psychiatrist and training and supervising psychoanalyst who's from Mumbai. So thank you very much, sir. And I am genuinely looking forward to the insights that from the psychoanalysis perspective also that you would like to share with all of us today as we discuss the cases. So welcome to both our faculty. I will just share the screen just a second. So for everybody attending today, this is the fourth of this series that we're having. And we have our faculty with us. And we also have 3 of our residents who will be presenting scenarios. So I have a brief few slides where we just go through a little bit on the concepts in very brief, because you have a lot of information in the books, like Sir said, but we've just tried to kind of consolidate it here. And we will also have remarks from our faculty, followed by we will go with the 3 presentations that our residents have, Dr. Neha, Dr. Shubham, and Dr. Mithil. So the focus in the cases, rather than what is the diagnosis or the entire history, is more related to the specific scenarios or incidents where they have observed any of these phenomena and their thoughts related to that, which we can also go ahead and discuss with the faculty following their presentation. So with that, I request our faculty, Dr. Khyati and Dr. Amit, to give some opening remarks regarding the topic. Khyati, ma'am.
Thank you. Thank you, Sri Lakshmi. And thank you, Sushil, for considering me for such a topic which is very dear to my heart. Now, my focus will be mainly on therapeutic and practical aspects, not the academic ones. Exam mein khud hi dekh lena. So, good morning with this. I wish a very good morning to all of you. Now, when we hear terms like transference, countertransference, and boundaries, many of us immediately think of psychotherapy textbooks or psychoanalytic theory. But the truth is that we encounter this phenomena almost every day in clinical practice, whether we are able to recognize them or not. In simple words, transference is what patient starts feeling towards us, and countertransference is what we start feeling towards the patient, and the boundaries are what help us use those feelings therapeutically without allowing them to interfere with our treatment. One thing I have learned over the years is that patients do not bring just symptoms into our clinic, but they bring in relationships, maybe their past relationships. Some patients see us as a parent, some see us as a rescuer, some see as a brother or sister, or the only person who would understand them in their whole life. And sometimes, without realizing it, even we begin to respond emotionally in such a manner. I remember a young girl around 17 to 18 years old who had come with severe anxiety. Her father had schizophrenia, and because of his illness, the entire family had gone through years of fear and emotional trauma. and he would get very violent too. So, as her treatment progressed, she started calling me frequently. Initially, I thought these calls were helping her. But then she started saying things like, "Ma'am, when I talk to you, I feel peaceful. I feel so good talking to you. Without talking to you, I don't get that peace." That was a very important learning moment for me. I realized that she was not calling me for medical advice. She was calling because talking to me made her feel safe. The phone call itself had become anxiolytic. And one of the most important lessons I learned from that was patients sometimes become attached not to our treatment, but to the sense of safety that they experience in our presence. And as psychiatrists, our job is not to become indispensable, but our job is to help patients function without us. So, gradually, with empathy but clear boundaries, I reduced that dependence, encouraged her to use her own coping skills. I stopped picking up her calls and made a boundary setting that you can call me only if such things are there, not otherwise. Another patient was a middle-aged gentleman with chronic depression, who was with me for many years. He lived in a very emotionally difficult environment, often felt judged and misunderstood. During sessions, especially when he spoke to me alone, he would open up in the way he could not with anyone else. And over time, I noticed that the therapeutic relation became very important to him, and his mood depended on my availability. His mood started become like uh, was swinging with my availability. Like if there was a long waiting time, he became upset. If I could not respond to his message, though a genuine message, he used to become upset. At one point, he told me, "You are the one of the most important persons in my life." And then he asked me, "For you, I'm just a patient, right?" That question stayed with me because many patients eventually ask some or the other version of the same question because they want to know, do I matter to you? So, most boundary challenges in psychiatry do not arise from dramatical ethical violence, they arise from attachment. Patients want to know whether they are special, whether they occupy a unique place in our minds, and our challenge is to remain warm, empathetic, and emotionally available without becoming emotionally indispensable. I remember telling him, "I'm not in your life as a person. I'm as your doctor, as your therapist. Yes, I care about you and I genuinely want to help you, but my role in your life is different." And I think that captures what healthy boundaries are all about. Good boundaries are what allow us to be compassionate without becoming entangled. So, if there is one message I would like all PGs to remember today is when you find yourself wondering why this patient so attached to me, why am I feeling so much protective about this patient, or why am I feeling irritated, helpless, or overly responsible? अरे यार ये patient ना आए तो अच्छा है. These feelings are there in most of us for many patients. So that's why understanding transference, countertransference, and boundaries is so important for every psychiatrist. With that, I look forward to today's case discussions and the learning that will emerge from them. And I would also like to listen to our another faculty, Dr. Amit. So over to Dr. Amit.
Hello, good morning. Thank you, Sushil, and thank you, Sri Lakshmi. Am I properly audible?
Yes, sir. We can hear you.
So I just talk from a personal experience. So when I entered my post-graduation, I had I think 10 seniors, and for some strange reason, you start feeling comfortable with some and start feeling a bit uncomfortable with some. And again, difficult to explain why, but I was very comfortable with Sushil, and somehow he must have also felt fondness for me. Because of that, over a period of time, he started mentoring me. and helped me a lot with my studies, helped me a lot with my work. So I think this is out of the psychiatry purview. This is fondness of one person for another. How does it develop? Exact mechanism, nobody knows. But what we can know is that something unconscious or subconscious has taken place. That some personality cues, some non-verbal cues have been picked up, some gestures, facial expressions, something has been picked up by one person from another person, and it goes inside, it intermingles with their perception of life so far, their experiences of life, and you happen to like, dislike, be fond of, be comfortable with, uncomfortable with, feel irritated by, hate, lots of emotions, or even attracted to. Lots of emotions start taking place. This is what we call transference. Something that happens very spontaneously, very intuitively, without we fully understanding why we are feeling so. Now, when we take it to a therapeutic place or therapeutic relationship, then the feeling of countertransference develops. Like, for example, if you look at this relationship between me and Sushil Bhau, from my perspective, then what I'm feeling is countertransference in response to what he felt. And if we look at it from his perspective, then what he's feeling is countertransference to what I'm feeling, to my transference. And if we take this to the clinical setting, then as therapist or psychiatrist, the therapist is the one who will be having some countertransference, and the patient will be having transference. But these are interchangeable terms. They are not hard and fast. It's the same thing which is labeled in a different way because of the setting. Now, what I'm trying to say is that countertransference is not necessarily always disruptive or negative. It also helps us. The tricky part, particularly, I think, comes when the attraction comes in. That is where the boundaries are most likely to be breached. Any of the, like if we are working in a personal relationship or personal setting, then spontaneous feelings should make us think. Whether we are disliking somebody, we should think why. If we are liking somebody, we should also try to think why. And give it some time for things to evolve, and then take actions accordingly. The tricky part is when one feels attraction, one is also feeling excited. So the judgment gets suspended and the breach in boundaries happen. So if it makes us feel alarmed, or it makes us feel aware that, okay, well, this is what is happening here, then probably one will be able to think more about it and act on it in the right way without acting out or without breaching a boundary. And we should also be aware of something like that happening from the patient side. So this is all that I will say, and I'll wait for the presentations. Maybe we can talk about some examples later. You're on mute.
Siri, please unmute.
Thank you to both our faculty for their opening remarks. So something that began, if you see the textbooks, the initial mention starts with the psychoanalytic process and Sigmund Freud, Anna O, and from there the description about the whole cycle or the thought process behind this, and how when psychoanalysis was explored, it was looked at to actually bring these feelings of transference onto the therapist so that there can be resolution of this. So those who are interested in learning more, reading more can go. There's a lot of depth actually to today's topic, but keeping in mind the purview of that this is for our postgraduates and something that has a time limit, we will be sticking to a very superficial or like more like skimming over the topic. Those who are interested definitely can go and read up much more about what is there. So to kind of just put together all that we have heard our experts talk about, that these are unconscious processes. And when we talked about transference, we heard from both of them that this is what comes from the client or the patient onto the therapist. And in a way, these are certain feelings, expectations, attitudes, or basically relationship patterns that are coming from their significant past relationships. And most often it is with some important attachment figures. So those emotions or feelings, those come onto the therapist during this client therapist or patient doctor relationship. And you could have it go both ways. It's not always negative. You can also have positive transference, which both work in their own way in affecting the therapeutic relationship. And when we understand this, it also gives us insight into the client's world, as well as their many of them have recurring interpersonal difficulties. So this would also give us a window into that, and could be a very important focus when we are looking at psychotherapeutic exploration as well as change. And countertransference, like our faculty said, it is the other way around. So it is the therapist's emotional, cognitive, or behavioral responses to the client. So this could be the therapist's own past experiences coming up in that interaction or relationship. It could be just a response to the client's transference as well, and also where things stand in the ongoing therapeutic relationship. So again, this is a valuable source because a lot of unconscious dynamics are playing here. And countertransference, like Dr. Amit has very rightly pointed out, it has strength when we recognize it and we reflect upon it. So I keep telling my residents also that whenever something happens, take a moment, think about what actually played out there, so that it's a learning for you in able to recognize things. If unrecognized, well, it can interfere with treatment and often also contribute to boundary problems. And boundaries in psychiatry become very important because we interact with our clients or patients at a level or discuss things at a level which probably many of them never talk about to anyone else in their lives. So that's where having a idea of what are the appropriate roles and interactions and maintaining those boundaries so that our therapeutic environment can be safe and professional is of very, very utmost importance. And this definitely protects the client from exploitation. It maintains trust and therapeutic neutrality. It also helps in exploration in that safe environment and preserves the integrity. And today's day and world where there is a lot of medical legal aspects also coming in, and I think Sushil sir also mentioned in the introduction about how with digital age coming in, it's quite different or quite difficult at times to define clear cut boundaries. It becomes very important from all these aspects as well. And boundary crossing versus boundary violation, well, we all know, there are patients when they have something very happy, they bring sweets to the OPD to, give to us when they're coming to meet us for some situation. Or there are certain, like even personal disclosure related, sometimes they do ask, where are you from? Or what is, are you staying here? So there are certain elements where for therapeutic relationship, we do sometimes accept those sweets or yeah, but then give it to everyone. It's not my personal gain, but then I also look at our culture and the therapeutic relationship and take certain things. But boundary violations are where there is a definite no-no, because somewhere there is a cross in what is happening, and it's definitely going to be one party violating the other's boundaries, privacy limitations. So they are definite no-nos. And where boundaries, we look at boundary areas in psychiatry: self-disclosure, giving gifts, any form of physical contact, communication outside sessions, where there are dual relationships or multiple relationships, financial interactions, and sexual relationships. And Dr. Amit has already pointed out about how when there is physical attraction or attraction of some form, how it becomes difficult in the therapeutic relationship unless we are able to reflect, understand, and deal with it. So, sexual relationships, whether with current or former clients, is definitely a serious ethical boundary violation. And responsibility for maintaining boundaries definitely rests with the therapist, though it is a relationship, therapeutic relationship that we are exploring, but we are the responsible ones in this scenario. So, this is just a brief about these aspects. And we have our three presenters. So I think we already heard a lot of examples from our faculty. We will take these scenarios and I think take further discussions as we go with them. So the first case scenario we have with us, we have Dr. Neha. Neha, are you here?
Yes, ma'am. Good morning, ma'am. Good morning, respected seniors and my dear colleagues.
Dr. Neha is JR3 from GMC Chandrapur and will be joining us for this case that she has presented. Yeah, go ahead, Neha.
I am JR3 in GMC Chandrapur, and I would like to present a case which I experienced in my residency. So, this was a 32-year-old male admitted 2 years ago in our IPD setup in GMC Chandrapur with complaints of low mood, anhedonia, decreased energy at work, suicidal ideation, and he improved with inpatient care, and then he was called for follow-up on discharge. So, what I observed on follow-up was that he always insisted on seeing me. Despite the crowd, he used to wait for 3 to 4 hours to take follow-up with me. And then on one occasion, he brought me a pen with my name engraved on that pen. And one time, he even brought me a chili pepper spray, telling there was a recent a sad incidents in Arjikar where there was a rape of a resident doctor. So next day he brought me a chili pepper spray, telling that he needs my safety, so he's bringing me these things. And then once he even offered me that if I am having some educational loan, he would like to repay the loan. So what I did, I clearly declined all of his this offers. And what we can learn from this is there was a transference from patient side, that is gratitude that I treated him, and idealization that only this doctor can help me and this doctor is great, and dependency that he is unable to manage without me. So these scenarios, what I sensed, and what we have to learn here is this, in this situation there can be a feeling to a doctor that doctor can feel proud about himself by the patient's admiration, or there can be a pressure to treat the patient special, and so we all have to avoid that. And there was a clear boundary violation also, that he brought me a chili pepper spray and then he offered me to repay my educational loan. So this was a clear boundary violation. So how we can manage this? By respectfully acknowledging the gratitude, but politely refusing whatever he was offering, or being in financial involvement. Then also we have to explore the meaning, that why he is doing this, what he is feeling. And then I discussed with my seniors, and then they guided me that how to cope with that patient. Thank you.
Dr. Kathy, Dr. Amit, anything you want to?
I would just say that it's well managed, nicely and sensitively dealt with. Nice to know about that. I was just trying to think about the psychoanalytic perspective. Generally, when there is any kind of therapeutic relationship, we call it as there is some regression, seeing of the therapist as a paternal figure, and an automatic regression happens. So from that regression, there's a lot of very deep and intense feelings can start coming out. The difficult part of it is that the intensity of feelings is coming out not in a child, but in an adult mind and body. So it goes through its own complications because of the adulthood, because of the sexual drive which has developed, which would be absent in children. If a child would do some of these things to you, you wouldn't really mind. You would be happy to take it. The child makes a greeting for you. You'll be happy to do it. It's the same mechanism, but complicated by an adult who is capable of violating boundaries, and who's also is also complicated by the sexual drives that start coming into play. So only thing I think, as you've managed, is to respectfully handle it, sensitively, not make the patient kind of feel rejected. But sometimes one has to take very strong steps also, because these may not really be amenable to simple measures. So yeah, I mean, it is important to be aware where it is happening and to deal with it. Thank you.
Thank you, sir.
I would like to say, am I audible?
Yes, ma'am, you are.
Yes. I would like to say, Neha, you very well managed, just as Dr. Amit said. And here, the thing, like the patient was progressing in the sense he started with a pen, then he like gave the pepper spray. So he was very clearly concerned about your safety, means he was thinking a lot about you. Whenever he heard of something that happened in Arjikar, he immediately thought about you. Also, when he started thinking about how he can help you, so that is why he volunteered for the educational loan. So he was thinking a lot. It was, I think, simply more than transference. He wanted a place in your life and he was climbing the stairs. And at the right time, you stopped him. So that is the best thing you did.
Thank you, ma'am.
Thank you, Dr. Neha. I think many of us may have come across such scenarios in some form or the other. In some, maybe something lesser, but in certain scenarios, maybe even going beyond. So, like our faculty have pointed out, being able to pick out that this is something which is, so when it is a pen, nobody really thinks so much, because I mean, it's just a pen. But how this scenario teaches us how it's progressed, and if we are actually observing this and reflecting upon this, I think it gives us also an idea of when and where we need to really clear cut place the boundaries and ensure that they are not getting violated. So thank you, Dr. Neha, for bringing up such a wonderful case. Yes, Dr. Amit.
Just one small addition, yeah, pen, but I think she's mentioned that the pen had her name engraved on it, which is a little small red flag that, as Dr. Kathy is saying, there's a lot more thought going behind it, not just superficial thing. The person might be quite entangled in the intensity of feeling. So just to notice small things which later on help us more.
If this case were in therapy, sir, what do you think would be the next step? Like, this was more on an OPD settings where they were coming to see her in the OPD and get the treatment. But what if this was in therapy?
If it would be in therapy, then it will have to be handled in a different way. Generally, these kind of scenarios happen after, this happened after the patient improved from depression. In therapy, for a patient to improve from depression takes a significant time. So generally, some therapeutic relationship, some attachment, some trust has been usually formulated, and from that we start looking at it. I mean, of course, it has to be accepted first, and from there one has to start exploring. Like, okay, well, I understand you feel like that, but what does this mean? Like, where is it going? Where is it coming from? What is happening inside of you? They also start talking more. It will not just be a gesture, but they will start mentioning you lots. They might start mentioning dreams, including the therapist, in different scenarios. Sometimes they themselves get very scared that, well, why am I having these kind of problems? Why am I getting attracted to or attached to my therapist? Sometimes they drop out because they themselves are scared, particularly if there is a gender difference. So it has to be handled very sensitively. But again, if it starts going beyond control, because again, in the room, it's only you and the patient. So some mechanisms have to be in place. Again, if it is happening like this, then it can be very stimulating or arousing for the therapist. So the therapist also has to have a damage control mechanism where he discusses with a supervisor, or a colleague gets a third person perspective. So those kind of things will happen.
Very briefly, I would like to tell that I had many male patients who were showing the thing was more than transference. With some of them, I could discuss that out. And like, why was I so significant to them? What I like personally me, what they saw it like, were they associating with somebody, something of their past or something, and some of them could relate to that, and I could help them out. There were two or three who were not ready for that analysis or that therapy. So I stopped seeing them, and I recommended that they should see some another therapist.
Right.
Just a thing to add,
Yes, sir.
again, in therapy, them talking about it is welcome actually. So if so long as they are talking about it and we are trying to work on it, it is fine. But if a physical boundary violation would happen, then at least that session has to be terminated. They have to be reminded that we can talk about everything, but you cannot try to touch me or breach the physical boundary. So that has to be done. It becomes very tricky with children, adolescent, that bracket. They're not clearly adolescents. They're not clearly children. Sometimes they want to hug you. They want to, do something. It becomes a little tricky, but again, it's a child, so it is different from an adult.
Right. Thank you so much. Thank you, Dr. Neha, for bringing in such an interesting case with a lot of insights.
Thank you, ma'am.
Thank you. We have another resident with us here, Dr. Shubham. Dr. Shubham Keval Ramani is from NKP NKP Salve Institute of Medical Sciences and Lata Mangeshkar Hospital. He is in second year, right, Shubham?
Yes, ma'am.
Yeah. So you can go ahead with your case. Yeah.
Good morning, everyone, to the faculty and all the participants attending the session. So I'll be presenting a case of transference, countertransference, which was a personal experience. I hope I'm adequately audible.
Yes.
Yeah, you're audible.
So it was in the mid-January, earlier this year, when I had just entered the second year of my residency in psychiatry, and had also taken up the role of admitting patients directly from the casualty, along with the house officer duties I had. So we had admitted a 35-year-old female from Wardha, who was a known case of bipolar 1 disorder, and she had presented in a manic episode with mood-congruent psychotic features. She was accompanied by her elder brothers, who were her primary caregivers. They were all Sindhi speaking, and belonged to the same community as mine. She happened to be one of the first patients I was seeing independently, and I had to inform about directly to the faculty. Also, it was the first time that I got an opportunity to decide and opine on a patient's endo management. So when the patient got to know my name, she became more comfortable, and the rapport was easily established. Even the relatives started approaching me more often regarding any doubts or for my opinion on anything regarding her stay there. She would often refuse to take her night medications or the short-acting insulin doses for her raised sugars, for which I had to be called every time to the ward to convince her. Even my co-PGs would sometimes call me or complain to me regarding her relatives being non-cooperative and ask me for solutions. By the fourth or the fifth day, she offered me a new set of earphones from her family store as a gift, and also inquired if I was single and would be interested in getting hitched with her niece, to which I politely declined. Gradually, I found myself taking more interest in discussing her case with my senior residents and the rest of more than the rest of the patients. Be it the diagnosis, the treatment plan, the decision to not start her on ECTs, I was very much involved and opinionated. I started seeing her first, both during my morning and evening rounds, evaluated her in more detail, used to trace her investigations faster, and also took almost daily counseling sessions of the family members in the evening. After almost 21 days, the patient got discharged, and she reported around 90% improvement with good insight. While leaving, she again offered me the earphones, which this time I accepted. And she also apologized for anything inappropriate she had said or done during her stay. Since then, she has been one of my most compliant patients and follows up in the OPD every 2 weeks, along with following the diet and lifestyle modification I had advised. On certain occasions, I would reprimand her for not taking care of her diet and exercises when her sugars came out raised and her OHA doses were to be hiked. There have been multiple instances when she has waited for more than 3 hours just because I was not available in the OPD or was busy in my ward duties or in my rounds. Following which I shared my phone number with her brother so that they could pre-decide the follow-up and the time and date, or even for any emergency, which was very unlikely of my usual practice. Soon, after a couple of months, when I was outposted in my psychotherapy posting for a month, on one of her follow-ups, she had presented with significant EPS, and I found myself making a detailed treatment history of hers, leaving behind and forgetting about my patients who had come for psychotherapy. And I realized this as a problem only after one of my colleagues pointed this out to me. After this, from the next follow-up, I started avoiding seeing the patient by myself. Either I would tell them that I'm currently not posted in the respective posting, or direct her to one of my juniors, or would ask someone else to tell them that I was not in the OPD whenever I saw them entering. In the past couple of months, there have been two instances when the patient has come later in the evening presenting with excessive tremulousness as EPS. And on both days, I was not the on-call resident on duty. But as soon as I got to know about these calls from my colleagues on our WhatsApp chat, I would voluntarily go to the casualty from my room and see her and make the necessary treatment changes and give my advices. So overall, as I look back to these past 6 months, a retrospective assessment regarding this case, it has been that uh, since childhood that I've been pushed by my grandparents than my parents, that they wished for me to learn the cultures and traditions, and to know and speak the language, our language, which over all these years I've somehow failed to fulfill and often feel guilty about. I somewhere hold the affinity towards the people from the community and want the contentment of doing my part in some way. So I think that's the reason for the countertransference, which is, I think, still going on, and I don't know how, haven't been able to completely manage it. Thank you.
Thank you so much, Dr. Shubham, for such an honest, sharing that you have. It takes a lot of courage to come onto an online platform and talk about, but I think what you have presented here genuinely tells us how we ourselves, without realizing, end up doing a lot of things, and it's only when we reflect we actually understand what's happening. So, our experts, your points or thoughts on this, and anything that you would like to discuss.
Yeah, I mean, as you said, Srilakshmi, Shubham, very nice. Like, I think the complicated part of the whole thing is, if it is about other emotions, we are easy to talk. We can talk about them. But when it comes into this zone of feeling some affinity, attraction, affection for somebody, it becomes very difficult for us. We start feeling as if we are already doing something wrong. Whereas these are natural feelings which will happen to you, it can happen to me, it can happen to anyone. It doesn't matter. What matters is how we are handling the situation. And are we aware of it? And most of the times we are not aware of it until a certain time limit. Depends on our awareness. You are just starting, so of course you are still learning. You will become more and more aware of it as you go ahead. But this is very important that you bring it up and take some help for these kind of things. A lot of things, as you said, you are also reflecting on your life and where things could be coming from. And I think that's the key of handling such situations. I would highly recommend that one should definitely, in such situations, look inside, try to figure out why I'm feeling like this, what is making me take these steps, and try to also now suddenly now you're in a learning setup, you are a part of the institute, so it's a different thing. But when you will be in private practice, these things are very difficult to manage because the patient is directly connected to you and is going to be a part of your practice nevertheless. So good that you're bringing it up at this point and trying to deal with it in this way. I'm very happy and encouraged about it. It's a very honest presentation. Thanks for it.
Thank you, sir.
So, Shubham, even I congratulate you for being honest because it is really difficult to open up on a platform like this. Having such feelings of countertransference is really normal, I would say. And many of the residents or many of the psychiatrists do experience this. So, having the countertransference is normal, but crossing or violating the boundary is not ethical. And that's what you haven't done. Countertransference also, besides attraction and affinity, it also like reflects on some of your own deeper feelings, maybe your past, like something is being brought to the surface by that relation, or by the way she is talking to you, or by the way she is treating you. Some under things are being brought to the surface. Maybe you need to look up to that as well. And sometimes minor boundary crossing is still okay, but violating boundary is never okay. So this is what we all need to keep in the mind.
If I can say one more thing, I think there is a study mentioned in Kaplan which talks about younger, more attractive, well-dressed patients tend to get more time in the consultations as compared to older, non-attractive, same gender patients. So it's not really uncommon. A lot of times unrecognized for sure. But that's why I'm saying that it's very nice of you to have brought this up and spoken honestly and openly about it, because we do need to talk about this thing. Without talking, they can't be managed. So yeah, that's all.
Thank you. And I think this also very often leads to burnout on the part of the therapist or the treating psychiatrist also, because like you brought out in your case, you are posted somewhere else, but you're running to get this done. I have seen residents, there are certain situations or scenarios where yes, we do sometimes go a little out of the way to help the relatives, but then when it starts becoming too much with a particular patient, I think like you have sat down and thought about it, it is still an ongoing process. I'm sure there's a lot more that you have to work on, and you are in very capable hands at Lata Mangeshkar with our own Sushil sir and all faculty there. So I think you need to sit down and think about the aspects as well, because many residents then start experiencing burnout. And like Kathy ma'am said, there comes a point where I don't know why this patient is coming. Maybe they just shouldn't come to the OPD, or they just shouldn't be around. So that is something that we don't want to reach eventually. So if you're able to work through and kind of manage things, I think it becomes easier on us also. And having a supervisor talking to sharing, residents don't want to talk about these things sometimes, but I think that's where being open about what's happening, sitting down with your mentor or guide and talking about it would be very helpful. Thank you, Shubham. You've brought out an entirely different aspect of to the topic when compared to what Dr. Neha brought out. So thank you very much for that honest presentation. The third scenario that we have Dr. Mithil here, who's J3 at AIMS Nagpur, to share the case. Mithil, are you here?
Yes, ma'am. Good morning.
Good morning.
Good morning to all the faculty members and fellow colleagues. So, I will be sharing this personal experience that I had with one of these patients who was a 21-year-old female pursuing BSc nursing and diagnosed with severe personality disorder, having borderline traits, and admitted with a single depressive episode, moderate severity, after an attempt at self-harm with high intentionality and lethality. Subsequently, during the course of her treatment, she had absconded the premises. And then later on, the plan was that she will return home with her father in 2 days. Now, 1 day later, uh, I received a phone call from an unknown number. And when I picked up, she introduced herself, and she was in distress, where she voiced out help, saying that I am in danger, my family member might harm me, or I might do something to myself. When this had happened, it was around late at night. Uh,
Rajvika?
uh, she was heard, and I heard her concerns. After hearing her concerns, I told her that this may not be the correct mode of communication and time of communication, and I tried to uh, end the conversation there. Wherein after this, I immediately informed it to the consultant. The consultant alerted the father as per the protocol, and subsequently, I blocked the number such that such crossing might not occur ahead. Here, the transference which I felt was that a patient had idealization and dependency on me, and as she had interrupted the treatment process in between and left, she might have had felt the abandonment, which is uh, core to her diagnosis and her course of experiences, such that she idealized me as a rescuer or a safety object, and in that crisis situation, she reached out. What I felt when I had gotten the call was that I was apprehensive as to what might happen, what might she do to herself, or what might her family members do to herself, such that it started to make me feel helpless in that situation, and helpless when I would talk to patients with similar profile or similar profile or similar situations. But herein, how I had managed it was that I immediately had set the boundary, and then subsequently informed as per the risk protocol and managed it. Here, what I felt that the counter transference I felt of the helplessness, of the apprehension, was somewhere not mine to start with, but retrospectively, it was a useful information which told me some things about her internal state, and then this that situation was subsequently managed. But what I learned from this situation particularly was how the process of projective identification was underlying, and how at times I would feel hopeless or helpless when I would be dealing with patients with similar profile. I would give them more time during my consultations. I would go beyond certain aspects of therapeutics which might have been decided for the time. And as I became aware of it, I started to realize which emotions are mine to process and which are not mine to process, and subsequently be more aware of the same. Thank you.
Thank you, Dr. Mithil. Dr. Amit, Dr. Kathy?
Thank you. It's a very good example. Borderline personality disorders are very difficult to manage because they also bring in extremely intense emotions with them. And again, it is very difficult to understand where the things are coming from. Sometimes they are coming from a place of manipulation, and sometimes they are coming from a very genuine place because they actually vacillate between feeling really good to in the depths of depression. So it's a very normal fluctuation that they will go through. As Sri Lakshmi was asking a bit, it will be handled differently, very differently in therapy and very differently in psychiatric settings. Keeping your boundaries firm is very important, because otherwise you start feeling the protector, and you start feeling like, okay, well, what unfortunate situation. In fact, one of my seniors, when in my first posting, had said that if you start feeling too intensely for somebody, be aware that, or be alerted that this could be a borderline personality you're trying to deal with. Beyond that, I think Dr. Kathy will take up.
I also had a few queries as to, see, here probably the patient didn't have transference. What I felt, what she called, that could have been a micropsychotic episode as well, looking to her borderline personality. As Dr. Amit said, like their reactions or those range from manipulative to genuine. So for her, if it was a genuine micropsychotic episode and she was really under panic that somebody might harm her, then informing her doctor, that is a natural reaction. Like, we cannot say that it is transference. And the what your consultant advised and what was done, like informing her father, was the best part that could have been done. Now, you're feeling hopeless or helpless. That is particularly not for this patient, but particularly for this situation, I guess. Is it right? Like when
Um,
such things come up.
it was for this situation, and
Yes.
also at times when I would deal with patients with a similar profile.
So
Uh,
borderline, you mean to
Border,
say?
yes, yes, ma'am.
Yeah. So again, this is dealing with borderline patients is again a very, very different and difficult issue, I would say, because they have that extreme range. Sometimes they trust us so much, we are God for them, and sometimes they treat us like we don't want their good, or we want to maybe harm her, or at least we are not helping them, etc.,
Mm.
etc. So we have to maintain a neutral stance during all of that. When the patient says, like, you are the only person who understands me, at that also, at that time, we don't have to feel too much high or special. And when the patient says that you are like this and you are like that, at that time also, we don't have to feel bad. We have to understand that this is a pattern of those patients. This is how they behave with their surrounding people, and that is what is transferred to their relation with the therapist, that is us. So in such situations, rather than reacting, responding, first you analyze, and then you will get the answer, like how calmly, gently but firmly we have to deal with such patients, not getting dragged away into their emotional pull. So
Mm.
then you will stop feeling this helplessness, because you'll be able to see uh, uh, you can be an alien and see the things. So then you will not feel that helplessness, I would say.
Yes, ma'am.
I think this case also brings to the forefront what Gawande sir started with initially about how, with the digital era coming in, I mean, earlier you would have patients coming to the emergency or coming to the hospital, or a relative coming and telling you that something like this is happening or they're feeling this way. But now it is, you're just a button click away. So at any time there are messages or calls happening at random times that such things are happening. So it's also, especially in patients like this, where both our faculty have told about how the emotions are so intense and they keep fluctuating. So even for the person who's dealing with, there's always this question mark. I mean, is this genuine? Is it not? And we are always taught that when you're assessing in terms of self harm or suicide risk, you always err on the side of caution. But now this person is not even in front of you. You don't know really how to reach out. This message or call is the only medium of exchange, and that I think also brings in a lot of sense of helplessness when especially you are on the one handling it, and more likely as a resident. So I think that is also something that has come up in this case, I believe. So thank you, Dr. Mithil.
Thank you,
And
ma'am. Thank you, sir.
since I was the consultant with him on the case, ma'am, I can tell you the thing is with the phone call, why we consider transference is because she went away from the hospital. She absconded actually because she was trying to meet some her boyfriend who her father was not approving of, and she left without informing any of us. So she had all our numbers because we were all trying repeatedly to find out where she was. We had no idea.
Okay,
She
but
switched
then
off her
how did
phone.
you know that she was going to come back in 2 days if she went
No,
without
no, she
informing?
came back. This is after that,
Acha.
ma'am. So when she
Okay, okay.
contacted him, actually she had all our numbers because her own faculty, me, him, we are all at different times trying to call or contact, and she had our numbers. She had spoken to us also, but she chose specifically in that situation to call him.
Okay.
So that is where we thought in retrospect that this could have been an element associated.
No, actually, for a psychoanalyst, everything is transference. Things are chosen for a particular reason. So, default, it is transference. How it is handled is a different thing. How one chooses to think about it is a choice that you always have to execute. But it is like everything will be a transference situation. You can think of it in an impact way also.
Thank you. Thank you so much, Mithil. I think
Thank you,
we've
ma'am.
had
Thank you,
three
sir.
very diverse and wonderful case scenarios which our postgraduates have presented. And like we have been discussing, it takes a lot to come onto a platform like this and be honest about experiences. And I think for those who are listening, and when this topic was posted and there were requests for people to volunteer, there was a lot of silence. Many people were not sure about what to talk about or what to present. So I think our residents have done a wonderful job on the presentation and the discussion. So thank you so much to all three of you. And I think with this, we are drawing to a close. And this is just what Dr. Kathy also summarized at the end of the scenario, that transference is what the client brings from the past, countertransference is what the therapist would experience, and boundaries are that framework which will allow both to be used in a therapeutic manner. So, with that, we come to the end of the discussion. Both our faculty, I would request you to kindly give your closing remarks.
Well, from my side, I'm really happy to hear that people are thinking about these things. We don't think enough about such things. I also believe that countertransference is very helpful in making a diagnosis, though it is not part of our diagnostic formulation. Generally, like for example, I would say the kind of countertransference in euphoric mania will evoke, dysphoric mania will evoke, and a schizoaffective mania will evoke are very different. With experience, you will learn what is happening. Another example that spontaneously comes to my mind is about somatic delusions. Many times you start feeling somatic sensations, and for a third person, it will be difficult to know who's the patient, who's the doctor. That kind of intensity of physical transference also you can feel, countertransference. We will call it countertransference, but technically it's also transference only. So that, I mean, it will help differentiate somatic delusion from a somatization, one would say. So, if you are aware of what is happening inside of yourself, body and mind, slowly you learn how to observe things and what to do with them, how to use them for help.
Dr. Kathy?
Yes. So I would divide it into 2 to 3 things. Like for transference, for females especially, romantic, sexual, that's in that area the transference is very much we have observed. So the females have to set boundaries very, very clear. Obviously, the vice versa is also true. But for the females, I'm telling, they have to set the boundaries very, very clearly, like what they can do, what they can say, what is allowed and what is not, and when to continue the patient and when to discontinue the patient. For counter-transference, I would say that count counter-transference may be helpful to the patient, maybe you can say harmful to the patient. If we are having counter-transference, just reflect upon ourselves, just analyze that and see like what can you take out of it, take out of that, and turn it in such a way that it becomes helpful to the patient. For example, self-revelation. Sometimes when the patient is saying, you start identifying yourself with the patient, like मेरे साथ भी ये सब ऐसा ही हुआ था. So you reveal yourself, you reveal your past experiences. You should do that only to help the patient, not for your own ventilation. That's it. And always be aware of such feelings of transference from the patient and counter-transference from your side. And be aware of the boundaries, which Sri Lakshmi very well narrated in the slides.
Thank you to our faculty. If anyone has any questions, you can put it into the chat box so that we can take that up. In the meanwhile, Sushil sir, do you have anything to add?
Yes. First of all, thank you, Amit and Kathy, making this session so interesting. And I would rate this session one of the very, very important and interesting session out of the many sessions we have conducted over last 1.5 years. To all the students who are here and all the faculties, including Sri Lakshmi, I often categorize psychiatrists in two. This is very often I say in my lectures: psychodynamic psychiatrist and psychodopamine psychiatrist. So there are few psychiatrists, they pass MD, but they are till a very late in their practice, they are more like psychodopamine psychiatrist. And there are very few psychiatrists, they soon after their MD, they are psychodynamic psychiatrist. So those who are psychodopamine psychiatrists during their initial phase of practice, mostly those who are of a male gender, they often fall in something with a borderline female patients. So they have to be very cautious when dealing with the borderline female patients, because dopamine receptor, D2 receptor, and that receptor will not solve many problems. And if you just limit yourselves to the dopamine receptor and antagonist, sometimes you can land up into problems. So we have to balance this both the things. When over the years, then we learn that okay, it is psychiatry is much beyond that dopamine and the serotonin receptors, and there a role of psychodynamic comes. So we have to balance ourselves with both the things, psychodopamine as well as psychodynamic, so that we will prevent the therapeutic relationship from going into something which could be problematic for the therapist, for a doctor, as well as for the patients. So thank you so much, both the
We have
faculty.
one question which has come in, sir. We can
Yes.
just take that. And so we talked a lot about patients with personality issues and difficulties, but there is a question that has come up also about managing countertransference when dealing with patients of addiction.
I would say countertransference, negative countertransference while dealing with the patient with addiction would arise from two things. One is our own basic, you can say that childhood thing कि पीना खराब है या addiction खराब है, ये तो drug addict है, etc. So many of the psychiatrists might be having that thing in their mind deep rooted. So that is what would from the beginning drive the psychiatrist towards the negative side कि अरे यार ये लोग कैसे आ गए. And another thing is that patient of addiction would repeatedly like go on to that cycle of de-addiction and again relapse into the drug, de-addiction and again relapse into the. इसमें ये कितना समझ क्यों नहीं रहा, मैंने कितना समझाया. From that also that negativity comes into the psychiatrist. So in that, I would say that rather than firstly labeling a patient of addiction like alcoholic or drug addict or something, just look at the neurobiology of the patient and think in that way. Even in when the cycle of addiction, de-addiction is repeated, then also you look at the neurobiology, that it is the circuit of the brain of the person which is going on doing its job. And our task is to break that circuit somehow and repair that circuit. So think in those terms, then you will have less this negativity towards the patient. If you start seeing the things scientifically and biologically. I think Dr. Amit was adding something.
No. I agree with that. That is more or less what one would think from.
I think that's the only question we have in the chat box. So, and yeah, we're also almost slightly overshooting time as well. So, though I don't believe, I've not realized how this last 1 hour has gone. It's been really amazing. So, thank you so much to our both our faculty, Dr. Kathy and Dr. Amit, for joining us this Sunday morning for such a wonderful session. I think somewhere like Sushil sir was saying, while going from psychodynamic to psychodopamine, a lot of these concepts are now kept as only something to be looked at before exam, or just something that you need to have know few lines about so that you can put something down on paper. But today's discussion has brought out about how important it is throughout residency as well as throughout one's practice as a psychiatrist. This is going to come back time and again. And of course, if you are someone who's going to further go down the line of psychoanalysis and explore therapy on those lines, then builds up another significance altogether. So something that has significance day in, day out. So thank you so much for the wonderful session. Thank you to all our three residents who presented and took the courage to come on this platform and talk so openly about the emotions and difficulties and discussions that they had. And to all the residents who are attending, if there are some of you who have missed out, who would want to see this session again, it's going to be there on the West Zone YouTube channel. So you can definitely go back and revise, or let your colleagues know who have missed today's session. I can see Mishra sir, thank you so much for being there for today's session. Sir is always enthusiastic and supportive when it comes to all sessions related to PG students. So thank you so much for your backing and being there with us always. Thank you, Sushil sir, and all the members of the committee. We will keep coming back to you every month with more and more of such things. I think exam times are coming up soon, so there will also be revisions in terms of mock viva and sports, etc., which we will catch up with soon on the WhatsApp group. Thank you so much. Thank you, everyone.
Thank
Thank
you.
you.
Thank you. And Sushil, I really loved those terms coined by you, psychodynamics and psychodopamine.
Thank you. Thank you so much. Bye-bye.
Bye, everyone. Have a great Sunday. Thank you.
Yes, sir. Bye.